Good morning, Docpreneur Nation. My name is Michael Tatro. We have as a special guest today, Dr. James Januzzi. Dr. Januzzi, thank you for being with us.
Hey, thanks, Michael. It's great to be here. Glad to join you.
Dr. Januzzi works with Mass General Hospital. He's also a Hutter Family Professor of Medicine at Harvard Medical School. I'll let you go ahead and kick us off.
Super. Thanks very much. For the next 15 minutes, what I want to try to do is give a good background for how we have looked to improve the diagnostics and management of patients with suspected or even known coronary artery disease. Because ultimately, for us as clinicians, it's about understanding as much as we can about our patient and then targeting therapeutics as best as possible. So what I'm going to talk about today, Michael, are two different blood tests that have been brought to the bedside. There's one that's called CVE, or cardiovascular events. This is a biomarker panel that was developed to predict the 1-year risk of heart attack, stroke, or cardiovascular death. The second panel is another really unique and interesting panel that we developed that has been refined to predict the presence of obstructive coronary artery disease, the CAD-HS panel. Agreed? Yeah, no, I completely agree, which is why at their core, both of these blood tests, although yes, it's Friday afternoon and we love talking about the science behind it and the biomarkers and the artificial intelligence that was used to create the algorithms, etc. At their core, both of these blood tests are telling us something that we deal with every single day in the office, right? And when a patient comes to me in the office and says, I'm worried that my father died of a heart attack at age 50 and I'm 65 years old, and I'm worried about my cardiovascular risk factors. My LDL is 90. Should it be lower? My blood glucose is fine, but my A1C is 5.7. Should it be lower? Those are patients that are very common in our practice because, among concierge physicians, among folks like myself who have a very concierge-like practice at the MGH Heart Center, we have patients that are very well informed. They know where to find information about lowering their risk factors. But the question is that good enough? Are we delivering the kind of care that our patients, the individual patients sitting in front of us, should be receiving? We know that getting LDL under 100 is good. We also know that getting LDL under 70 for high-risk patients is better. We also know that in the Improve It study, getting LDLs under 50 for the highest risk patients, the really highest risk patients, is even better. We also know it's safe. We know that therapies like GLP-1 receptor agonists reduce atherothrombotic complications, even in people without diabetes. So ultimately, when it comes to our patient who's sitting in front of us, who is concerned about their individual picture, that's where tests like this can be really useful. In and of itself, those results give us very actionable information. And no, my friends, in the medical world, we do not all lower our patients to LDLs under 50. We do not have all our patients at blood pressures of 130/80. The simple truth is a lot of our patients are resistant to that kind of aggressive treatment, but if given a reason to accept it, many more would be expected to accept it.
Amen. And that goes along